Hello everyone and welcome to my channel Meds Corner. So it's me Tithi, Dr. Tithi Barua, intern of ESIC Medical College. So today I'm going to discuss a topic from orthopedics. So first I want everyone to tell me what is this? This thing I'm indicating, not this oozing of this blood, not this one, but this huge thing. Okay. So if you have diagnosed it as a giant cell tumor, then you are very correct to the diagnosis. So, what is giant cell tumor? Giant cell tumor is also known as osteoclastoma. It's a benign tumor, but it is locally aggressive. It more commonly occurs in female than in male and more in a skeletally mature patients. And it commonly occur in the age group of 20 to 40 years in the epiphyseal-metaphyseal junctions. So what are the sites where the giant cell tumor can occur? The most common site of giant cell tumor is the distal end of femur. Then we have the proximal end of tibia and the distal end of radius, proximal end of humerus, hands, spines, ala of sacrum and the vertebral bodies. In the distal end of the radius, giant cell tumor is the most common tumor which occur in the distal end of the radius. Then what are the symptoms a patient present with having giant cell tumor? Symptoms being swelling. So because of the swelling, because this is a it makes the it has that property to cause bone destruction and even has a malignant potential. So this easily can lead to bone fractures. Then there is decrease in the movement and pain at at the nearest joint where it is occurring. So what do we find clinically? Clinically, we find eggshell crackling appearance. This is very important. Eggshell crackling. Then how do we diagnose this case? Diagnosis is usually done with the help of X-rays. In X-ray, we find soap bubble appearance. That is the eccentric lesion, which are not lyrics. This will be lytic lesions. Sorry for my mistake. These are lytic or the translucent lesions, which are usually seen. Now, what happened? These I'll show you with the example of X-ray. So these are the so this is what we can appreciate. This is the distal end of radius. This is ulna. So this is basically the wrist joint. X-ray depicting the wrist joint. So this is the distal end of radius. So what here we can see is the lytic lesion. That is the giant cell tumor. So this is basically a soap bubble appearance which we appreciate in the X-ray. And these lesions it's not never, it's rarely extend this direction towards the articular cartilage here. Towards the articular cartilage, it's rarely extend, but it mostly extend towards this side. That is towards the, it will breach the cortex and can it extend towards this skin side. So it breach the cortex and extend in this direction. Now this completes the X-ray finding, that is the soap bubble appearance. Now if we go back, what you will see in pathological finding. So it contains large multinucleated giant cell additional to mononuclear stromal cells. So here whatever the mononuclear stromal cells we find, these are nothing but the neoplastic cells. These mononuclear stromal cells are the neoplastic cells. Acts as neoplastic cells. Then we have the giant cell. So the giant cell which we find here, they act as a osteoclastic activity, that is directed through the rank L pathway and lead to bone destruction. So this is the reason why we find such lytic lesions. Now we are coming to what are the differential diagnoses of this case. So giant cell tumor differential diagnoses are, first is the hypoparathyroidism, that is brown tumor. So this hyperparathyroidism, one of the feature is the brown tumor. So there will be multiple lesions, that is giant cell lesions. But how we will differentiate it with the giant cell tumor? By hyperparathyroidism. So there will be increase in serum calcium level. hypoparathyroidism. Like this way we can differentiate it from the giant cell tumor. So other thing where we can find giant cells are the aneurysmal bone cyst in fractures, in chondroblastomas, where we will find giant cells. So these things has to be differentiated from giant cell tumor. Then second diagnosis is the epiphyseal tumor. What are the epiphyseal tumor? That is the chondroblastoma and the clear cell chondrosarcoma. So this chondroblastoma usually occur in young patient, and chondrosarcoma, clear cell chondrosarcoma, occur in adult patients. Then we have the now this chondroma. We have when I was discussing what are the sites of sites of giant cell tumor, I have mentioned sacrum. So in the sacrum, giant cell tumor occur in the ala of the sacrum, but chondroma, which occur in the central location, has to be differentiated from giant cell tumor. Now, how do we treat this case? So there are two options. Either we can go for the medical treatment or for the surgical treatment. So for medical treatment, we have bisphosphonate and denosumab. So let me mind you this. What is denosumab? Denosumab is nothing but the human monoclonal antibody. It is directed against the RANKL pathway, which is responsible for the bony destruction. So this we usually use denosumab in recurrent cases, or if it is a huge giant cell tumor where surgery could be a bit risky. Then if we can also go for the surgical treatment, that is aggressive curettage and adjuvant therapy. Now what we do, if suppose this is a bone where you find this giant cell tumor, so we curettage this area along with some normal bony area, so that we remove this area. Now after removing, what we do, after this removal of this thing, we put here some bone cement, and or we can say bone graft, just to fill up this position, to fill this gap. To fill this gap, we put some bone cement or some bone graft to fill this gap. And then what are the adjuvant we can use? So this will completely make a structure, or sometimes we do resection and reconstruction of the bone as well. Now what are the adjuvant therapies we give? We usually give phenol, hydrogen peroxide, or cryotherapy as an adjuvant therapy. So this is all about the giant cell tumor. I hope you like the video. Thank you.